Ellie is a 28-year-old female with a complex and chronic medical history, namely spina bifida and myelomeningocele. Initially admitted to the PICU for post-op care following an incision and drainage of a superficial abdominal abscess and a VP shunt externalization. Her course has been very complicated and prolonged by cardiac arrest, multisystem organ dysfunction, diffuse alveolar hemorrhage, pancreatitis, and respiratory failure. She's requiring ongoing respiratory support and management of mechanical ventilation. Ellie, in addition to the past medical history I mentioned, also has a history of chronic kidney disease with hypertension, a solitary right functional kidney, recurrent nephrolithiasis, prior left vesiculourethral flush, status post a distant left ureteral and hydronephrosis with a chronically neurogenic bladder. Also with pancreatitis, this admission, which required surgical intervention of a drain about 6 weeks ago. Prior to this admission, she required no respiratory support, was comfortable at home on room air, and mother reported a very good quality of life and infrequent hospitalization. She also does have a history of AFib and prolonged QT. She lives at home with her mother, who is also the power of attorney. Ellie's been intubated for 31 days with inability to wean from the ventilator. Over the past several days, we've been working towards a goal of extubation, and she has tolerated pressure support trials for 24 hours a day for the past 4 days. Yesterday, CPAP was trialed, and after 30 minutes, she was returned to pressure support due to an increased work of breathing. She was tachypnic, tachycardic, and had low-grade fevers. She's remained febrile and tachycardic today despite attempted fluid bolus and extra respiratory support. For objective data, her weight is 37.8 kilos today, which is up from yesterday a bit. Overall, with weight loss, this admission. No known medication, food, or environmental allergies. For immunizations, she's up to date on all of her childhood vaccinations, including her annual COVID and influenza. Vitals for the last 12 hours, as I mentioned, she's been febrile, about 38.5. Tachycardic to the 150s, with her baseline being about 100 and 1 teens. She's been normotensive, 110s to 1 teens over 80s, 70s to 80s. A bit more tachypnic, breathing 20 to 25 over the ventilator, with oxygen saturations 90 to 100%. For eyes and nose, she was positive 120 this morning. Labs, her CBC was pretty unremarkable. Her CRP and ProCal have been uptrending a bit, which isn't unusual for her, but definitely noted given, new fevers today. For the culture from the CSF fluid out of the EVD site is currently with no growth or WBCs. Chest x-ray today was a bit difficult to visualize due to the degree of her scoliosis and difficulty to see the diaphragm, but there is presence of atelectasis and consolidation in the lower bases with infiltrates bilaterally. On physical exam, generally she was alert, awake, shaking her head yes and no to questions today. Obviously limited with communication given an endotracheal tube. Her FX flat. Her breathing is definitely more labored today compared to yesterday. Neurologically, as mentioned, she's alert and oriented. Her EVD is in place at 10 and draining, and cranial nerves were intact. Respiratory, she's intubated and ventilated. Her lungs sounded coarse to me bilaterally with adequate air movement. Definitely diminished in the bases. I did not hear any wheezing or extra sounds. She was a bit more tachypnic with mild nasal retractions. No intercostal or subcostal retractions. Sputum from the endotracheal tube is thicker today, but white. For head and neck, The right EVD site is open with sutures in place. It's clean, a bit moist with minimal drainage at the site. Neck is supple with no adenopathy present and an artificial airway in place. From a cardiac perspective, she's tachycardic with a normal rhythm, a bit diaphoretic. Extremities were warm and 2+ pulses bilaterally with a cap refill of less than 2 seconds, and she remains normotensive. Her abdomen was soft, distended at baseline with a hypoactive bowel sounds present. She has a pancreatic drain in place midline, and it had dark brown soft output in the bag this morning. Her NG tube is in the right nair, and she remains NPO. From a musculoskeletal perspective, she is non-ambulatory with limited range of motion in her upper and lower extremities and hips and spine with scoliosis. She's able to move her upper extremities a bit more. Her wrists, she can transfer objects between her hands, and she can do a grasp bilaterally, but definitely a bit weaker. No tactile sensation below the waist. Her legs bilaterally are in a chronic contractured frog-like state with minimal movement, able to even passively kind of retract her out of those contractions. Her tone throughout is hypotonic and no edema present in her lower extremities. Her skin, as I said, is a bit more diaphoretic today compared to yesterday. Warm throughout, no rashes. She has on her right wrist an old IV irritation red site, but it's blanching, maybe 2 centimeters in diameter. The abdominal surgical wound site is clean, dry, and intact. For access, she has a right chest tunneled central line and a left peripheral IV. For FENGI, so my impression for Ellie is she's a 28-year-old female with a complex history, as mentioned above, and a prolonged complicated course due to setbacks of cardiac arrest, pancreatitis, diffuse alveolar hemorrhage, and inability to part with the mechanical ventilation. Now with a worsening respiratory status and concerns for infection based on the return of these fevers. Problemless health maintenance. Developmentally, she is delayed about a 3rd grade level per mom's report. Fevers and respiratory failure. For differentials, initially we were thinking dehydration with the presence of tachycardia, but was ruled out when she was not responsive to fluid bolus. Withdrawal was another consideration given that she completed a tapering of methadone Ativan wean, which ended yesterday, but her Watt scores for the days prior were between 1 and 2, and the wean was very slow, so that was also ruled out. Also, we are considering infection and chronic respiratory failure, just secondary to her underlying progression of her medical condition. By systems and plans, so respiratory, we're going to discontinue the CPAP trials for now until we get, kind of a better grasp on what these fevers mean. We're going to return to her prior ventilator settings. So she's on the Draeger with a pressure support of 10 and PEEP of 5 with FiO2 at 21%. We're going to continue her prednisone at 3.5 milligrams BID, which is 2 times physiologic. Per endo, we're doing a slow wean given just her chronic steroid use from the pulmonary hemorrhage. And we're going to monitor respiratory status closely and get a chest x-ray tonight. For cardiac, we're going to maintain her pressures, normotension, with a MAP goal of 70 to 80, which she's been in, and hold her home lisinopril. Neurologically, as I mentioned, she completed the methadone Ativan wean yesterday. We're going to continue her EVD at 10 and replace the output with 1-to-1 ratio. Internalization plans are on hold for now. Last conversation with neurology yesterday, actually, they wanted her to be extubated prior to considering that. We're going to continue Keppra prophylactically at 630 milligrams BID. Continue her melatonin, 3 milligrams at night for insomnia, and Zyprexa, 5 milligrams as needed. We're going to try to use the Zyprexa at night and avoid benzos and Ativan as possible for delirium. FE and GI, we're going to continue NPO status with the complete bowel rest. Is recommended by general surgery for at least 60 days. So she'll continue on the TPN and lipids. For nutrition, omeprazole will continue at 40 milligrams BID for gut protection. We'll continue the K-phosphate, 1 tap daily, and vitamin C and D to promote wound healing. We're going to hold her home bowel regime and maintain the pancreatic drain and monitor its output. For kidney, we're going to get daily weights, Lasix as needed. We'll continue her home regime of intermittent straight cats every 3 hours with a bladder irrigation every 6 hours. And also her home oxybutynin 5 milligrams BID, and monitor her horizon O's closely. From an infectious disease perspective, she just completed a 7-day course of cefepime last night for a UTI, and immediately upon discontinuing that, fevers returned, which kind of seems to be her baseline or her pattern this admission rather. We'll consult ID for their thoughts on just this infectious picture, and also monitor her fever trend very closely and give Tylenol as needed for those temperatures above 100.4, and she can get Tylenol 10 mg per kilo. We are going to work up the fever, so we'll get a CBC with differential, CRP and Procal. We'll get blood, sputum respiratory cultures, as well as a CSF count and culture and a urinalysis. For skin, we're going to continue to monitor skin integrity, reposition every 2 hours given that she's non-ambulatory, and the special pressure alternating bed. For access, she does still need her central line for TPN and IV meds and her peripheral, and we're going to continue NPO status. From a social perspective, we're going to call mom today just with an update given the change in her clinical status, the new presentation of the fevers, and just her kind of worsening respiratory status, as well as just to share overall concern of how long she's been intubated for, and the possibility that weaning from mechanical ventilation, although we're going to continue to work towards that, could be very difficult. So a meeting with palliative care may be helpful next week, just to talk about all the what ifs if we are not able to wean from mechanical ventilation, what their goals of care are.